What is stable angina? Stable angina is predictable chest pain. Very important word, predictable. The pain usually happens when the heart works harder. For example, during physical exertion, during emotional stress. Why does this happen? Because in those moments, the heart needs more oxygen. The myocardial oxygen demand increases. But here's the problem. The coronary arteries are already narrowed by atherosclerotic plaques. So when demand increases, supply cannot increase properly. This creates a mismatch. Oxygen demand is high, oxygen supply is limited. That mismatch causes ischemic chest pain. That is stable angina. Pain characteristics. The pain is usually described as pressure, tightness, heaviness. It is commonly felt in the front of the chest, but it does not always stay there. It can radiate to the neck, the shoulder, the jaw, the arm, especially the left arm. And now, the most important clinical feature. It is relieved by rest. When the patient stops exertion, oxygen demand falls, the mismatch reduces, the pain disappears. That is why we call it stable, because it follows a pattern. Why is stable angina dangerous? Never underestimate it. Stable angina means there is underlying coronary artery disease, and coronary artery disease can progress. It can lead to unstable angina, myocardial infarction, stroke, sudden cardiac death. So stable angina is not mild. It is a warning sign. Special type, Prinzmetal's angina. There is another type called Prinzmetal's angina, also called vasospastic angina. This one is different. The cause is not plaque. It is coronary artery spasm. The artery suddenly constricts, and very importantly, the pain occurs at rest, not during exercise. This is a key exam difference. And remember this carefully. Beta blockers may worsen Prinzmetal's angina because they can allow unopposed alpha-mediated vasoconstriction. That line, exam favorite. Aims of treatment. When we treat angina, we have two major goals. First, control symptoms, reduce chest pain, improve quality of life. Second, prevent future cardiovascular events, prevent myocardial infarction, prevent stroke, reduce mortality. So treatment is not only pain relief, it is also secondary prevention. Always think long-term. Drug treatment. We divide treatment into two main parts. 1, antianginal therapy. 2, secondary prevention. Acute attack management. During an acute attack, first-line drug is glyceryl trinitrate, or GTN, usually given sublingually. Why sublingual? Because it acts rapidly. It avoids first-pass metabolism. It gives quick relief. Mechanism? It causes venodilation. That reduces preload. Reduced preload means reduced myocardial oxygen demand. It also dilates coronary arteries, so both supply and demand improve. That is why it works so fast. It can also be used before exercise as prophylaxis. Long-term symptom prevention. First-line drugs are beta blockers. Examples include atenolol, bisoprolol, metoprolol, propranolol. What do? They reduce heart rate, they reduce contractility, they reduce blood pressure. All of this lowers myocardial oxygen demand. Less ischemia, less pain. That is why they are first line for stable angina. When beta blockers cannot be used, if the patient has decompensated heart failure or Prinzmetal's angina, then beta blockers are not suitable. In those cases, we use rate-limiting calcium channel blockers, such as verapamil, diltiazem. They also reduce heart rate, reduce contractility, reduce oxygen demand, so they can replace beta blockers. Dihydropyridine calcium channel blockers, example, amlodipine. These mainly cause vasodilation. They are particularly useful in Prinzmetal's angina because vasodilation helps relieve spasm. If one drug is not enough, if beta blocker alone is not controlling symptoms, we can add a calcium channel blocker. But be careful, do not combine beta blocker with verapamil because both reduce heart rate strongly. This can cause severe bradycardia or heart block. Very important safety point. If combination is still not suitable, according to NICE guidance, we can add one of the following: a long-acting nitrate, ivabradine, nicorandil, ranolazine. Now understand them clearly. Ivabradine, it is a selective sinus node if current inhibitor. It acts directly on the SA node. It reduces heart rate, but it does not affect contractility, so it lowers oxygen demand without weakening the heart. Useful when heart rate remains high. Nicorandil, it is a potassium channel opener. It causes vasodilation. It reduces preload. It reduces afterload, so the heart works less. Good alternative option. Ranolazine, this is a piperazine derivative. It inhibits the late sodium current. That improves myocardial relaxation. It reduces oxygen consumption. It is useful when other drugs are insufficient. Monitoring. After starting or changing therapy, Review the patient in 2 to 4 weeks. Titrate to the maximum tolerated effective dose. If 2 drugs at maximum dose fail to control symptoms, refer to a specialist. That sentence is very important in exams. Secondary prevention. All patients with stable angina are high cardiovascular risk, so we must reduce future events. Lifestyle modification is essential. Stop smoking. Reduce weight, increase physical activity, provide psychological support. Drug therapy for prevention includes low-dose aspirin, a statin, and consider an ACE inhibitor, especially if the patient is diabetic. These reduce the risk of myocardial infarction, stroke, cardiovascular death. This is lifelong management. Revascularization. If optimal medical therapy fails, we consider revascularization, either percutaneous coronary intervention, PCI, or coronary artery bypass graft, ABG. These improve symptoms and in selected patients improve prognosis. Antithrombotic drugs mention cangrelor. This is a direct P2Y12 receptor antagonist. It blocks ADP-induced platelet activation, prevents platelet aggregation, used in certain coronary interventions. Eptifibatide. This is a glycoprotein 2B3A inhibitor. It blocks the final pathway of platelet aggregation, used in high-risk acute coronary syndrome settings. Now take a breath. Stable angina is predictable chest pain due to fixed atherosclerotic narrowing, triggered by exertion, relieved by rest. Acute attack, GTN. Long-term beta blocker first line. If not tolerated, verapamil or diltiazem. If still uncontrolled, add long-acting nitrate, ivabradine, nicorandil, or ranolazine. All patients, aspirin, statin, consider ACE inhibitor. If medical therapy fails, PCI or CABG. That is the full picture. Understand it like a clinician, not like a memorizing student. And once you understand the mechanism, you will never forget it. If this lesson helped you understand stable angina clearly, don't just watch and leave. Like the video, comment your doubts, share it with a friend who is preparing for exams, and subscribe, because we are learning cardiology step by step, slowly, clearly, together.